honored to be presenting to this group. As Patrick mentioned, we will focus on the current state of mental health and the mental health burden specific to Medicaid, but also in light of the pandemic and many of the factors that we are dealing with in today's environment. Just to get us started here and sort of set the baseline, I thought it would be helpful to discuss the burden and impact of mental health on Medicaid populations. I think, as we probably all know, Medicaid is the single largest payer in the United States that for behavioral health services and obviously including mental health care. Just a couple of statistics. In 2015, Medicaid covered 22% of non-elderly adults with mental illness. That percentage goes up for those with serious mental illness. You can see about 9.1 million adults with Medicaid have been diagnosed with a mental illness. And almost a third of low-income Medicaid beneficiaries have been diagnosed specifically with depression. When we think about those numbers and how staggering they are, it's quite astounding from a personal impact standpoint. And then when we look at the economics as well, 1 in 5 Medicaid beneficiaries had behavioral health diagnoses. And while it's 1 in 5, that accounts for about half of the overall burden. To put those numbers into a slightly different context, as we can see on the next slide here, if we look at this bar graph on the left, the TRD cohort, the treatment-resistant depression cohort, in mean healthcare costs per patient per year, you can see is much greater than non-TRD MDD specifically, as well as those that are not part of the major depressive disorder cohort. So, what this really says to me is not responding to those treatments, whether they be pharmacological treatments or behavioral interventions, clearly has a severe economic burden on the Medicaid population. And you can see the breakdown here. I won't go into detail, but whether it's inpatient, outpatient costs, other costs associated with that care, in basically every situation, they are increased as you look at populations that are not responding to their treatment for major depressive disorder. I don't think this will necessarily surprise anyone, although the statistics are quite staggering. From the Bureau of Labor Statistics, you can see the unemployment rate that has risen just since the pandemic. This data is from April. And obviously from an overall economic perspective on the GDP, you can see the changes there, and I know we're all familiar with that. When you look at some of the actual data, in terms of psychological distress, depression screens, prevalence of depressive disorder over the last year, again, some very staggering statistics here. You can see that 13.6% of U.S. adults have reported symptoms of psychological distress. The increase there, again, is quite staggering compared to where it was a couple of years ago. Depression screenings, as evidenced from Mental Health America data, shows the drastic increase and the fact that it's more pronounced in those under the age of 25. One statistic at the bottom here from the Kaiser Family Foundation, 53% of American adults report that coronavirus and the crisis is harming their mental health in some way. Certainly this is taking its toll, and I think the long-lasting effects of the pandemic will be evident from a mental health capacity for some time. Now, from a Medicaid standpoint, I'd like to applaud many of you on some of the actions that have been taken, since the pandemic started. And when we look at some of those, many of them are effective in delivering care, in thinking about ways to optimize care, and really get creative in terms of outreach to our populations that do need support and help. As we look at some of the specifics, telehealth services, how can we expand those and get access to the patients that can use them? Looking at, softening the refill too soon policy and getting medications to those that need access in an appropriate, timely manner. Disease management programs that can be handled online, mental health crisis lines, apps, are obviously gaining a lot of traction right now, and any way that we can provide the resources that are available and deliver those resources in more of a creative virtual setting. I think the other call to action that we really see here, and this is just pulled from a number of different journals as well as CMS and SAMHSA, but there is really a call to understand how other resources, can be delivered. What are some of those resources, and how do we think about, improving the effectiveness of these mental health interventions? What can be done, and what can we leverage now to enhance that? And today we'll be talking specifically about pharmacogenetic testing, genetic tests that can optimize medication selection for patients with depression and other psychiatric disorders. And I do think this fits into, this type of opportunity that we have. Let's think about how we can incorporate this technology, other technologies to really do all that we can for the population. And before we get into the specifics of the genetic testing, I thought it might be helpful to just set the baseline for what's happening today, in the treatment of depression. And this is data from a study that was done a number of years ago, but it was a very real-world clinical trial that just sought to understand, as you work your way through subsequent antidepressant trials, how do those patients perform? So I'll show you, walk you through a little bit of that data. But the way that the study was set up was basically a sequential trial, medication trials, based on response. So when you look at first line, second line, and so on, patients that entered the study started a first-line antidepressant treatment. Now, what we saw in that first-line treatment was, when we look at remission rates, about 37% of those patients were able to achieve remission. That is what you want. That is the goal of antidepressant treatment. Your symptoms are greatly alleviated, and you are doing much better. And you saw some of the data from the Medicaid population on treatment-resistant depression. As you get to second-line, third-line, fourth-line treatments, that's really defining that treatment-resistant depression population. So if you do not respond to that first-line treatment, you would move to second-line. You can see the remission rates drop, and this is the blue line here, at second line of about 30%. And then you see a much greater drop-off down to the teens, under 15% of those that are achieving remission for third and then fourth line treatment. Now, this is definitely the population that we focus on, where they're not responding to that first treatment. What can we do to help these patients? And at the same time, the green line is showing treatment intolerance or the side effects. So as you are working your way through these subsequent treatments, not only are your chance of remission going down, your chance of seeing side effects and intolerance to that medication goes up. So it's like a double hit mechanism here, whereby if you're in this treatment-resistant population, your likelihood of remitting is low, and likelihood of seeing side effects based on those medications goes up. So what are some of the factors that leads a patient not to respond to treatment? Remission is difficult to achieve, as you saw from that study, and here's some of the factors that go into that. There are high rates of non-adherence for patients that are taking antidepressants. Variety of factors, may lead to that. We saw some of the data on adverse effects. If your medication is causing you to be sick, you're likely to discontinue it. There's environmental factors, why a medication may not work. Hopefully not, but we all know the realities that cost and insurance can sometimes be prohibitive to getting a next medication. One of the less obvious factors, that we'll talk about today could be genetic variability. That's contributing to, hopefully identifying medications that may be more optimal for certain patients. Now, as we talk about some of those factors, that are inhibiting the likelihood of patients remitting, the reality is, in that STAR-D trial, in the data that we looked at, as well as the current standard of care, this is a trial and error process. Physicians, providers are tasked with taking all these factors into account. The patient experience, we talked about adherence, what's the family history, and ultimately deciding on a medication. Pharmacogenetics, the gene site test, is one component that can be applied to this treatment approach. Now, it's not the silver bullet. It's not the end-all, be-all to provide a specific medication, but when used in combination with clinical judgment and these other factors here, ultimately it leads to a more quantitative way to narrow down and decide on a medication for that individual patient. Clearly it's personalized in the approach, and part of that is based on the evaluation of how a medication is metabolized. So I'll walk you through this slide, but one of the factors that we study is the metabolism or the pharmacokinetics of the genes that we test, which ultimately lead to how much medication is processed by that individual. So when we look at the extensive or the normal metabolizer depicted in the green here, this individual would break down medications normally. So as expected, you would see typical levels of medication in their blood. Now, part of what GeneSight does is to look at those cytochrome P450 enzymes that can fluctuate in their metabolism based on the genetics. And let's go to the extremes here. You can see the ultra-rapid metabolizer in the blue. Kind of as you would expect, if you're metabolizing the medication very quickly, you're going to break it down very quickly. You're not going to have high levels of medication in your system. Now, in the ultra-rapid metabolizer situation, you may not see side effects. You're breaking it down quickly. You're excreting it from your body, but the likelihood of responding to that medication is low because there's not enough of it there. If you take the other extreme, the poor metabolizer status, you're breaking down medications very slowly. In this situation, if you take a normal dose, you're not able to break it down as fast as a normal metabolizer. You're going to see increased levels, and that's more often than not where you could see side effects if you're having higher or toxic levels of medication in the blood. So when we look at GeneSight specifically, how do we think about improving patient outcomes in major depressive disorder? There's a couple of factors here to consider. We've identified 12 genes, that are clinically important This is not a full analysis of the genome. It's specific to genes that have been identified in the literature to provide metabolism differences, like we just discussed, or response differences based on the pharmacodynamic genes that are on the panel. And we talked about the second bullet as well, but it really indicates patients who are least likely to respond to their treatment, and hopefully allows clinicians to use the test in combination with those other clinical factors to prescribe more suitable medications. And what we've seen in the data, which we will review some of that, is it identifies more effective treatments for MDD, which ultimately leads to improvements in remission rates and response rates as well. So what does the GeneSight report look like? Very simply, you can look at the figure on the right with the green, yellow, and red categories. This is the first page of the genetic report. So a provider is able to order the test, get these results delivered back, and then share them with the patient. But the medications are categorized, based on the level of gene-drug interaction. So the green category, is the use as directed. There's no identified gene-drug interactions from the genes that we study. If you look at the yellow and red, that's where the gene-drug interactions come into play. And anytime a medication ends up in the yellow or red, there's a clinical consideration, or the footnotes, the little numbers there. And you can see the meanings of those numbers on the left, but it provides the clinician with sort of a roadmap on why and what the reason is for that gene-drug interaction. So in some cases, it may be a dosing suggestion where the patient is metabolizing the medication very slowly. Maybe you want to consider a lower dose. And then there's the converse of that. A patient is metabolizing a medication very quickly. Maybe you want to consider a higher dose. And you can see the multiple clinical considerations listed here. And this is certainly a genetic report where the first page here provides the green, yellow, and red categories. As you look through subsequent levels and pages of the report, all the genetics are provided to the provider in terms of the genotype, the phenotype, exactly what was tested, and what the result of that gene is for that individual patient. As you can imagine, as you're looking at 12 genes, all of these medications, antidepressants are depicted here. There's also antipsychotics, anxiolytics, and so on across the psychotropic space. There are a lot of possible outcomes for these reports. So this report, is depicting one sample, one theoretical patient. Each patient's GeneSight report would look different based on those 12 genes and then the analysis across those genes. So I wanted to share a bit of data that has been performed on the GeneSight test. In order to sort of start that data analysis review, I wanted to touch on just meta-analysis and meta-analyses in general. Previously, there's a meta-analysis that found a significant association between pharmacogenomics-informed treatment and remission in major depressive disorder. So this was independently done a couple of years ago to look across pharmacogenomics and tests in the space. And we recently, just over the last couple months, published a meta-analysis that looked specifically at all of the clinical trials, the clinical utility trials for GeneSight, which includes 4 prospective controlled trials of just over 1,500 unique patients. All of these patients were diagnosed with major depressive disorder, and they had at least one prior medication failure. If you're not familiar with meta-analyses, this is what's recognized as class 1, level A evidence from many of the review guideline organizations. You can see some of them depicted here. So I will dive into some of those results of the GeneSight meta-analysis. So we're going to see 3 different outcomes. The first is in relation to symptom improvement, and this is looking at that level. Oh, sorry, I misspoke. This is looking at the remission rates over treatment as usual, which is the standard of care, when you look at the utilization of GeneSight. So I mentioned there were 4 studies on GeneSight. You can see those listed here, each of those 4 studies. And then we looked at the remission rates on the HAM-D17 as a depression rating scale, where you need to score a score of less than 7 to be in remission. And if you achieved that, you were categorized as remitting. And the overall result of this meta-analysis is a significant improvement in remission rates for those patients that were in the GeneSight group compared to those patients that were in the standard of care group. So we touched on the difficulty of achieving remission over the course of treatment. These trials were all 8 to 10 weeks long. So at the end of that time point, either 8 or 10 weeks, we did see that significance in the percent of patients that achieved remission if they had access to the GeneSight report at the beginning of the studies. So before I move on to that next study, I want to point out the study Graydon et al. That was done in 2019, was clearly the largest study. Because of that, we are able to analyze data from that study specifically, because we have a good amount of power and a good amount of patients, and look at the data in slightly different ways. And that's what we did here. So this is a sub-analysis of that guided study. And we wanted to look more specifically at the gene-drug interactions. So if you'll bear with me for one moment, I'll describe how this analysis worked. But we really wanted to understand how specifically the GeneSight report could be applied to look at those outcomes at that 8-week time point. And one way that we did that was to identify any patients that entered the study that were taking gene-drug interactions. So just to make that really simple based on the report, if a patient entered the study and they were taking a yellow or a red category medication, they were included in this analysis. So we removed all the patients that entered the study taking a medication in the green category, with the idea that the results would not be diluted by data from patients that were on baseline meds, the green category meds with no gene-drug interactions. So it allows us to focus a little bit more, and I'll show you those results across the 3 outcomes here. So there's a lot of data on this slide. I hope you'll bear with me as we walk through it, but if you look at the top data set, and you'll see this is the change in symptoms for either the GeneSight group in green or the treatment as usual group in gray. And what you see in this sub-analysis of those patients that are taking meds with gene-drug interactions is if they have access to the GeneSight report, you see a 27.1% improvement in symptoms compared to those that are in the treatment as usual with 22.1% improvement in symptoms. So you can see the statistically significant result here with a greater decrease in symptoms if you have access to the GeneSight report. And then the bottom 2 graphs here, the first being response, the second being remission, is just a binary outcome. Did you achieve response? Yes or no. Did you achieve remission? Yes or no. And what you see here, as you would expect, for both response and remission, is a significantly different improvement for those that were in the GeneSight group across both of these outcomes compared to those that were in TAU. Just to focus on the remission result here, You can see these are percent of patients. So 18.2% of patients achieve remission in the GeneSight group compared to 10%, 10.7% in the treatment as usual group. No, I hope you're sticking with me because I'm working through some more data here and more sub-analyses, but this was from the same paper. But we wanted to ask more specifically, what happens when you switch your medication? So we've talked a little bit about how to look at patients coming in on yellow and red. The study design allowed patients or really physicians to decide on what they wanted to do for that patient, meaning they may have wanted to add another antidepressant on top as an adjunct therapy. They could switch medications, they could discontinue medications, a lot of possibilities. And what this analysis did here was to look specifically at those patients that switched medications, meaning the provider discontinued one medication and added another medication. And the thought here is that it gets very specific to if you're utilizing the GeneSight report to make those recommendations or not. And again, these are 3 outcomes across symptom improvement on the top and then response and remission at the bottom. And just to hit you with the overall results here, you see significance and improvement across all 3 of these outcomes if you are in the GeneSight group and you're adding and discontinuing a medication compared to if you're in the treatment as usual group. And the treatment as usual group in this analysis is still discontinuing a medication and adding another. So again, to bring it back to the remission, you can see even greater rates of remission if those patients have access to the GeneSight report at the beginning of the study. So I will pause and just check in with you, Patrick, see if there may be any questions or anything. That was the bulk of the clinical utility studies. I will review a bit on the economics as well. How are we doing, Patrick?
We're doing great. I'd say keep on going. We do have some questions, probably best for the end. But I do want to remind our attendees, send them my way. Use that Q&A panel, the chat panel, select my name. Happy to address any questions. But you're doing great, Mike. Keep on going.
All right. Sounds good. Let's keep going. So, as I mentioned, from a clinical outcome standpoint, we have run a number of trials, that you can see here. We reviewed some of the data in terms of a meta-analysis, looking at the outcomes of all those trials combined, and then some specifics around the guided trial, the largest trial that's been completed to date on the pharmacogenomics for mental health. As we shift over to the economics, we've done a number of studies there as well, both prospective and retrospective studies. We will discuss one study in particular, the Optum study, to look at healthcare utilization, healthcare savings over a retrospective chart review. And to give you a little background on that retrospective review and the claims analysis, this was done by Optum and included ultimately 683 patients. It looked at costs and budget impact associated with GeneSight psychotropic and defined those as total payments, made to providers for psychiatric disorders. You can see it's not limited to depression. Some of the top disorders that were included in this cohort: depression, anxiety, bipolar disorder, as well as you can see the others. And the goal of this was to compare those members that had access and informed care with the GeneSight report to those who received the treatment as usual. And the Optum group looked over calculated payer amounts for each group over a 2-year period, 12 months pre and 12-month post index of the GeneSight report. And here's the results from that trial. So when we look at the treatment as usual group, you can see this is specific to those patients that were diagnosed with depression. You can see $9,863. That includes medical costs. It also includes pharmacy costs. We'll show you a little more specifically that breakdown over that 1 year period. And when you look at the GeneSight group, you can see for both for medical costs and pharmacy costs, there's an overall decrease in terms of the healthcare utilization and spend. Importantly, the cost of the test set in this study at $2,200 was included in that GeneSight spend. And you see the overall spend there of $8,631, resulting in about $1,200 saved per patient tested. Some of those drivers were fewer inpatient admissions, fewer outpatient visits, and less medication spend. And that would include medication spend in the CNS space, psychotropics, as well as others. To show you that breakdown a little bit more specifically, you can see the bulk of the savings that's generated is from inpatient and outpatient spend, while you see 36% in terms of the total pharmacy costs. And again, this is specific to depression in this cohort. So from an economic standpoint, that's one of the studies we've done and we've reviewed. We've assessed GeneSight in a couple of others as well. I won't go into detail on those today. In terms of the payer support for GeneSight specifically, Medicare does have a local coverage determination on the coverage of pharmacogenomic testing. The LCA, the local coverage article, acknowledges GeneSight and coverage of the pharmacogenomic test. United Healthcare Community Health Plan also provides coverage for multi-gene panels, including GeneSight, to guide therapy decisions, provided medical necessity for antidepressants and antipsychotics, and they have a couple criteria around that. And I'll walk through that just here, where the individual must be diagnosed with major depressive disorder or generalized anxiety disorder. The patient must also have failed at least one prior medication. It really gets back to the data that we've generated in our clinical studies, some of which we've reviewed, where the inclusion criteria included those patients that have tried at least one antidepressant. And really, ultimately, it gets to the discussion we were having earlier around treatment-resistant depression. So that patient population perhaps can benefit the most from pharmacogenomic testing. And then the final criteria set out by United is a multi-gene panel, that has no more than 15 relevant genes. I point that out because it's so critical in understanding which genes are actually clinically meaningful. And I mentioned that GeneSight has 12 genes on the panel. Those are the genes we've identified to be clinically relevant. A whole host of data across hundreds of genes really doesn't provide any added benefit in terms of optimizing medication selection for depression and other psychiatric disorders. Okay, and so I'll just take the last couple minutes here to discuss a little bit about some of the resources that are available and just from an implementation standpoint, how GeneSight is typically ordered. We do have a HIPAA compliant and secure portal, My GeneSight Provider Portal, really where the clinician is able to order the GeneSight test, look at the status, understand where it is in process, and the reports ultimately get delivered back to this portal. We've done a number of things, even in light of the pandemic recently, to understand how we can gain access, how providers can gain access to GeneSight virtually. So, not only is there the in-clinic testing, but the direct-to-patient sample collection as well, where a clinician can order the test. It can be delivered to the patient's home, and the patient can do the simple cheek swab and send it back to our lab for assessment. From a patient standpoint, this gets a little bit more specific into how the patient can receive the kit. But from a patient experience standpoint, as I mentioned, the clinician would initiate the order, identify that this patient is appropriate for pharmacogenetic testing. Through communication, with the patient, they would receive a message to alert them to this fact. We would collect patient information as well as PHQ-9, which is a patient-administered depression rating scale. Certainly, there's consent all along the way for any of these options. And then ultimately, as I mentioned before, the sample collection, can be done in the clinic or via these telehealth options. And it walks the patient through, quite simply the steps that are needed to collect the sample. It is a simple buccal swab with 2 cotton applicators in the inside of the cheek. And then it gets FedExed overnight to our lab. And within 36 hours of the time that we receive the sample, we will provide those results back to the clinician portal. So just to review briefly the details that we discussed today, we have generated that level 1 meta-analysis evidence for the clinical utility of GeneSight. What we see is that it improves symptoms, response, and remission rates for patients with depression that have failed at least 1 medication. And based on that data, it supports medication selection with the idea that we can reduce those gene-drug interactions. Part of the data, that we saw in terms of the sub-analysis with patients that were either switching or started on yellow and red medications is that we can improve patient outcomes with what we call sort of congruent decisions. So if they're making recommendations and ultimately prescribing meds that avoid those gene-drug interactions, we see improved outcomes for those patients. From a healthcare expenditure standpoint, we see the reduction in healthcare costs of about $1,200, and that's per patient per year. It's a once-in-a-lifetime test. The results are there to stay. So if you are, on your 2nd medication and ultimately maybe you need to be moved to a 3rd medication, you're able to revisit the GeneSight results over time. And then we discussed the coverage with Medicare and the United plans as well. One of the things that we also discussed, which we're particularly excited about, is that we can incorporate this into the telehealth care models, as well as the clinical models that we've been doing for some time now. So with that, I would certainly like to answer any questions that we may have. Patrick, I'll see if you have any questions in the chat or in the Q&A, and really appreciate the time.
Yeah, absolutely, Mike. We do have questions, and I will get started on those. There is still time, everyone. Like I said, feel free to send those questions to me via the chat or the Q&A panel. As we go through these questions, you still have time. All right, so let's get started. First question, was the cost savings, $1,231, statistically significant? The Optum claims analysis might not fully capture the value of the genetic testing, i.e. productivity improvement, quality of life, things like that.
Yeah, that's a great question. And, I can touch on that in multiple ways. The $1,231 in savings was specific to the MDD sub-analysis and also included the cost of the test. To directly answer the question, it was not statistically significant. And, when we looked at approximately 200 patients, that were in that sub-analysis, what we did see, and I didn't show all this data, but in the full cohort, we saw significant differences across those healthcare utilization outcomes when we looked at the 683 patients, that were in the trial. Part of the flex, if you will, in understanding the statistically significant value is related to the cost of the test as well. So as Optum, put in $2,200, certainly that's a price that can fluctuate. And, I think the other point, Patrick, that you mentioned around, productivity, quality of life measures, that was not taken into account from the Optum claims. And certainly data that we have looked at from a modeling standpoint, as well as an overall outcome standpoint. And I would agree, with the comment that you do see improved outcomes across those measures as well, both in our modeling studies and outcomes as well.
Awesome. Thank you very much. Next question. Can Mike speak to the use with patients who have a number of social challenges, such as homeless populations, how this kind of precision can help?
Yeah, absolutely. I think no matter, what that situation may be, homelessness or comorbidities, associated with depression. I didn't mention it, but, as you look at those comorbidities, and those could be psych-related, or just other physical conditions, whether it be something like cardiovascular illness, diabetes, the data is really profound to show that these comorbidities are associated, with depression. And I guess my comment would be, as we look to the outcomes, specific to things like inpatient claims, number of visits to the ER, as well as outpatient, claims. That's where I think we see the biggest impact. And, as you think about the comorbidities, if you're able to alleviate the depression in terms of getting on the right medication, we see alleviation of those other comorbidities and symptoms associated with them. I just find that so interesting. It's well documented in the literature, not tied specifically to pharmacogenetic testing, but if we are able to appropriately treat depression, you see improvements across these other conditions as well. And the consistency, with which that exists in the data, I think is really impressive.
Okay. Next question. How is the availability being communicated to providers in underserved communities in high Medicaid populations who can be helped by this?
Yeah, fantastic question. Part of what we seek to do at Myriad, and specifically to my department, medical affairs, is to educate, those providers that are treating high levels of depression. And that includes psychiatrists. It also includes primary care providers, nurse practitioners. And, I would say, we see a high level of testing within Medicaid populations. And with that in mind, we're able to educate specifically to those providers, that are seeing those patients. And that's from a medical affairs standpoint. Certainly we have the commercial team, focused on getting out in the field as well and raising awareness. And overall, we've tested a large number of patients, with GeneSight specifically, many of which have been Medicaid beneficiaries.
Good deal. Moving on. I noticed that you shared data on the impact of GeneSight on remission from the meta-analysis, but then symptom improvement in response reported in the second study. Is there a reason for the focus on remission? And did the meta-analysis find similar improvements in those other measures?
Yeah, that's a fantastic question. I think whenever you're reviewing a bulk of data, you do it quickly and not comprehensively. So I'll try to address that. To the last question first, the meta-analysis specifically did show significance for symptom improvement, response, and remission. So when we look at those three outcomes in the meta-analysis fashion, with all of the studies on GeneSight, you do see that significance. When we looked at the sub-analysis that was referenced, we looked across those three outcomes as well, and saw significance. And then when you look at each study individually, the power of the meta-analysis is you can combine all of them together. When we look at each individually, across the board, you didn't see significance in every situation for every study. So take the guided study, for example. We saw specifically significance in response and remission, and the symptom improvement analysis approached statistical significance with a p-value of 0.1. So as you assess those outcomes, across each study, by and large, you have significant improvements across the board, but I'll caveat that with it wasn't in every situation. I think the other part of that question was why the focus on remission. Remission per every guideline, in psychiatry, whether it be the APA, the American Psychiatric Association, the more recently developed CANMAT guidelines, which are the guidelines in psychiatry from Canada, all indicate that the goal of acute treatment in depression is remission, and acute treatment being, the length of these studies, sort of that 8 to 10 to 12-week period. And it's also the most difficult to achieve for a patient that's suffering from depression. To really, have your symptoms alleviated is the treatment goal. So that's why we focus so much on remission, and hopefully ultimately getting a greater percentage of those patients to remission.
Awesome, thank you. Next question. Is a new GeneSight test needed each time a new medication is being considered?
Yeah, so the answer is no. A GeneSight test, I think I touched on it a little bit, is once in a lifetime. It can be used, over time and over treatment for an individual. Each report has those 57 medications listed on it. And, obviously, as you think about subsequent medication trials, a provider is able to go back to that GeneSight report, look at what the next medication they may be considering and understand what the impact of the genetics can have, but it does not need to be ordered repeatedly.
Awesome. Next question. From my understanding, most pharmacogenomic tests have not demonstrated improvement in clinical relevant outcomes. What differentiates GeneSight? Yeah, that's such a great question, because pharmacogenomics has been around for a number of years. Pharmacogenomics itself is not new. I would say GeneSight and the process that we use is much newer. So as we think about some of the nuance of one pharmacogenomics application to another, historically, a lot of tests have looked specifically at single gene to drug interactions. And part of the power, of the GeneSight test is the ability to look at multiple genes in combination and really understand how those multiple genes impact a specific med. So, one way I like to think about it is it provides more of the genetic picture by looking across the relevant genes
on the GeneSight test than it would for just a single gene with any association. So as we develop more data, just from a field perspective, I think what you'll see is incorporation of more genes together will lead to better prediction of how those genes get metabolized, how the patient might respond to them, and it's again all of the genes that we're able to incorporate rather than just one at a time.
Okay, looks like we have one last question. For the Medicaid population, access to mental health services can be challenging due to issues around social determinants of health and stigma associated with a diagnosis. Given these issues, how do you see GeneSight impacting this particular patient population?
Yeah. Again, another. You're not throwing me any softballs here, Patrick, but I think that's really a great question, because when we think about the stigma associated with mental health, in this population and really any population, it sort of becomes a thought that it's all in your head. Maybe you can tough it out. Maybe you don't need to see someone about your mental health issues. And GeneSight doesn't answer those factors and those problems that we have in society. But the one thing I would say, about GeneSight and genetic testing in particular for psychiatry, it does provide patients with an idea of, why they may be failing medications or why a certain treatment might not be working for them. It's a real genetic biological reason that, at least anecdotally, I've heard from many patients that, it helps to have that reason. It helps to have an understanding that, it's not all in their head. There's a biological basis for switching medications or thinking about trying to get on a different one. And just to be clear, that doesn't solve the problem of the stigma of seeking care necessarily, but I do think it provides one factor and some a level of patient engagement that you may not otherwise see.
Okay, thank you so much, Mike, and everyone who attended. Those are all the questions. That was a great presentation. As a reminder, all attendees will be receiving a recording of this webinar on MHPA's YouTube channel. So that'll be a great resource for you. If you have any questions, I'm sure Mike would be happy to receive them. We'll send a follow-up email to you with that information. If you have questions that come up later on with your colleagues or whatnot, I'm sure Mike and the folks at Myriad are more than happy to chat with you. But again, thank you all so much for attending, for supporting MHPA. And Mike, thank you so much for that great presentation.
Thank you. Thanks, everyone.
Have a great afternoon, all.